As we give a medication continuously, as shown on the left, or at least chronically, as shown on the right, the blood concentration of a drug increases until a steady level is achieved. This is known as steady state or CSS. It takes 4 to 5 half-lives of continuous or chronic dosing every half-life to reach steady state concentrations, assuming first order kinetics. This is when the amount of drug entering the body is equal to the amount of drug being excreted. If we increase or decrease the dose, it would take 4 to 5 half-lives for the drug to reach a new steady state. Achievement of CSS is important for the onset of action of many medications. Furthermore, CSS cannot be achieved any faster than 4 to 5 half-lives. However, we can replicate CSS concentrations by using a loading dose in some instances. When the drug effect is dependent on CSS and a rapid effect is needed, for example, when we are administering pain relief or controlling an arrhythmia, we cannot always afford to patiently wait for the concentration to reach CSS. This is where a loading dose comes in. A loading dose is a dose that is higher than the maintenance dose, used to achieve concentrations that are necessary to compete with clearance so that the desired effect is achieved and maintained sooner. Before considering providing a loading dose, there are several things to consider. 1. Does the drug have a direct mechanism of action? If it is indirect, for example, SSRIs, then using a loading dose may not speed up the onset of action. We need to ask number 2, what are the risks of adverse effects with a higher dose? So the higher dose used when loading can predispose the patient to an increased risk of adverse effects. 3, does the clinical scenario require a faster onset of action? Not all clinical scenarios require a fast onset of action. We need to weigh up whether the benefit of using a higher dose outweighs the risks of using a loading dose.